I see some of the questions answered by Dr. Luai in writing, but we have to read some of them. Some of the questions were referred to the neurologists, so I'll refer radiology to neurology, to Dr. Suzan. Yeah.
Sure.
So, Dr. Luai, how are you? You are muted.
Hello? Yes, yes. I hope you can hear me. Yeah, I'm good.
Yeah,
It's such
good. I hear you.
a pleasure to join you.
Thank you very much. We have large number of attendees. We have 890, so something like 900 participants. The question to you, Dr. Luai, I saw you have answered many questions, but I have to repeat some of them. You emphasize on OCT,
yes,
optic coherence
yes.
tomography. Our problem
yes.
with the neurologist, when you order it, we don't get a report. We just get images, colors, waves, but no reports. Why is this? Neither from technician or from doctor.
No. So whenever the report comes, it just shows numbers. And if the ophthalmologist did not mention the numbers in their notes, then probably you will know about the numbers. I do my best in putting these numbers in my notes so the neurologist understands what I'm talking about. Sometimes I take just screenshots for the images. But now we understand the role of OCT more and more. And I think it's mandatory if you're working along a neurologist to let them know about the results of the OCT, the visual field, and the visual acuity. This is of great importance. So these inputs are very important to make sure that they are recorded in the patient's notes, so the neurologists know exactly what are we dealing with.
Thank you. Yeah. Okay. Go ahead. Something.
Yeah. Just the study that I just want to mention. It's the OCT, not the optic nerve. It's of the macula actually. And we think about it. It's just we're looking at the ganglion cells in the macula, and this is where the early loss happens. These images are not usually done automatically by the machine. So even if the ophthalmologist requested, they have to specify specifically they need to specifically mention the images that they're looking for. As I just showed it in one of the cases, that the early loss, we see it even before we see what we see in the optic nerve.
Okay, great. Thank you. Do you see adult or pediatric NMO spectrum disease?
So definitely more in adults. Most of the optic neuritis in children, I would say that we more and more understand that these patients have MOG rather than NMO. So NMO, as Dr. Suzan has mentioned, it tends to be in older patients. So younger patients, I don't usually see it. It happens. I suspect it when I see severe damage of the optic nerve. I suspect it when I see long enhancement of the optic nerve. So different things that tells me there's something going on in the examination. But the most common form of optic neuritis, I would say, in addition to idiopathic, it's the MOG. And usually these patients present with bilateral optic neuritis with optic nerve swelling. So with papilledema or optic nerve swelling.
Okay, great. Any difference between treatment of MOG disease and NMO?
Yeah, definitely. I mean, definitely the vision loss, the severity of vision loss in MOG is totally different than NMO. So NMO is a blinding disease, and this is how I treat it. MOG, usually these patients have good prognosis, so I usually treat them with IV methylprednisolone. However, NMOSD, I usually, when I suspect it, based on MRI, based on what I just mentioned in my slides, I usually maybe sometimes go straight forward to Plex. Yeah.
Great, thanks. Question maybe to Dr. Suzan. Is NMO disease fatal?
Thank you for the question. It depends on the relapses, because some of the relapses are quite severe. We not say fatal, it seems like a demyelinating disorder of multiple sclerosis. Usually that does not reduce the lifespan of the patient, except if the relapse is a severe one, but usually no, it's not a fatal disease.
But is it worse than MS?
In terms of disabilities, yes. Yeah, in terms of disabilities, yes, because severe relapses is not treated early, they can lead to permanent vision loss, permanent mobility problems. Unlike multiple sclerosis, patients tend to improve, and then over the time they can get worse according to the progression of their diseases. So both are not a good diseases, but so maybe it's worse than MS, yeah.
Yeah, you mentioned that MS treatment worsen NMO spectrum disease. Can we have explanation for this? They are harmful. Why?
Not all of MS
DMDs,
treatment.
I mean.
Okay. Yeah, not all of them. There are specific treatment that's being mentioned, like Tysabri, betaferons, not Tecfidera, natalizumab, interferons, so Cobaxone. These are the diseases that can worsen the NMO because the pathophysiology is completely different. So, because if we're talking about DMDs that works on a different area in the pathology of MS, it's not the same that when we talk about MS. So it's no point that you give a patient a disease that doesn't work on him, doesn't affect his pathology, but it's, I have no explanation why exactly it can worsen disease, but definitely doesn't work because the pathology is different.
Maybe pathology because it is water channel receptors are affected, aquaporine, while the others are totally different.
Yeah.
Question Dr. Luai answered in writing and referred to the neurologist. Do you screen patients with MS for aquaporine? We actually, the adult neurologists, whenever we see suspected MS, we do at the beginning all the workup, including MOG and NMO antibody, aquaporine antibodies. Do you agree, Suzan?
100%, especially with, as we mentioned, that the diagnosis of NMOSD at the beginning, if it is like the first attacks, or it's just a unilateral optic neuritis before involving the other eye, it can be confused with multiple sclerosis. So if our suspicion is high, so definitely we need to screen patients for both.
Thank you, great. There are many questions here. How can we prevent NMO spectrum disease? Well, in other way, are there any environmental factors, risk factors, toxic element, hereditary factors which can be preventable? I'm not aware of this. Any comments?
No, there is no specific gene that is related to NMOSD. So it's genetic, but the pathology can be triggered by some infections as well. So it has something in common with MS. So I don't think there is any prevention measure that can be taken to prevent the disease. But there is no specific gene, definitely.
Yeah. One question maybe you answered it. What triggers NMO spectrum disease? Any triggers? Why some people get it, or some people don't get it?
No specific answer for that, but it's again like multiple sclerosis. We don't know exactly what happens, what triggers autoimmune disorders.
Yeah, okay. Question to Dr. Alaa. This is from me. Yes. We always speak about long segment myelitis in the NMO, but we have short segment NMO spectrum disease. When we have short segment and aquaporine positive, this will qualify diagnosis of NMO spectrum. Any comments on this?
Yes, exactly. As I told you, in 14.5% of patients of NMO, the affection of the cord is not a long segment, it's a short segment myelitis. And in this condition, we have to rely on the other diagnostic criteria, which is affection of the gray matter of the cord, central aspect of the cord, and affection of more than 50% of the circumference of the cord. These would be in favor of NMO rather than MS, even if it is a short segment affection. Yes, short segment, long segment is pathognomonic, but even if it is not there, we can rely on other criteria, which is a gray matter affection, not white matter, and more than 50% of the circumference of the cord is affected. Will be diagnostic for NMO.
Thank you, Dr. Alaa. Great. Do we always need to do orbit imaging for NMO spectrum? I mean, do we focus on the orbit? We just screen the brain in general?
Definitely. Brain is diagnostic for NMO, but to have orbital affection and optic nerve affection with the characteristics bilateral long segment, post contrast enhancement, and even if the patches are not so clear, we can do the DTI and measure the FA value and mean diffusibility, the integrity of the fibers of the optic nerve. We can pick if the optic nerves have been affected or not. And if we find the affection is bilateral, this strongly points to NMO.
Thank you very much. Thank you. Great.
Thank you.
Can I travel with NMO spectrum disease? Any volunteer?
Yes, of course. If the patient is on treatment, definitely he can take his treatment and he can travel. Yeah.
Yeah, but we are COVID now. Maybe this is what behind the question.
For the vaccination, still we advise patients with NMOSD to take their treatment, the vaccines, and of course we have to be sure that the patient is not receiving any steroids before the vaccine, and have to be the isolation for 10 days after taking the steroids. But there is no harm that if the patient is already maintained on their treatment, their investigations are fine. I mean, the blood tests and everything is fine, so no harm.
Yeah, thank you. Again, Dr. Alaa, meningeal enhancement. Does it happen in NMO spectrum or NMS?
Yes, it is one of the patterns of enhancement in the brain. Usually brain enhancement is the most common types of brain lesions to enhance is the linear enhancement in the subependymal patches or patchy enhancement in the patches in the white matter. But a third pattern of enhancement is nodular meningeal enhancement. This can happen in NMO spectrum.
Great, thank you. Question to Dr. Suzan. What is the future of treatment for NMO spectrum disease? Maybe this meant satralizumab?
As I mentioned, the future for NMOSD is very bright because scientists think that the pathophysiology of NMOSD is more homogeneous than MS and it's more simpler than MS. So we already have been targeting 3 different pathways in the process of how the NMOSD pathophysiology. So now we have 3 medications, both are effective in different studies. We just mentioned today about satralizumab, and there are people also, there are some other patients that were taking immunosuppression, still they are keeping safe and they are doing well. And if they ask me, patient is taking some medicine of immunosuppression off label, is he indicated to change to any of these newer medication? We say no, because if the patient is stable in whatever medicine he is on now, whether it's steroids, rituximab, mycophenolate, or whatever, they continue unless they have a relapse, a severe relapse, then they can be shifted to newer medications. But definitely the future is very bright for NMOSD.
Thank you, great. How long you keep the patient on mycophenolate?
I think I just answered this question. Patient, as long as they are, yes, no, as long as they are doing fine, it should be for life, of course. But if the patient is doing, yes, if the patient is doing fine, he will continue on the same medicine. If not, then the patient can be shifted to other medications if his disease is not well controlled.
If we get side effects from mycophenolate?
Definitely, it will be another indication to shift and to change.
Yeah. Question, any dietary consideration for NMO spectrum, apart from healthy diet?
Not in particular diets, but we usually we advise for all diseases, whether MS or other conditions, for a healthy diet. And it's thought that Mediterranean diet is quite good for demyelination disorder. So a healthy diet in particular is something that we recommend for all patients.
Yeah. Tabbouleh and these things. No?
Tabbouleh.
Yeah. Any comments, Dr. Luai, on this?
One point
consideration for kids, yeah.
No, just maybe the Mediterranean, as Dr. Suzan has mentioned. One point that I just want to, that we haven't gone through, it's the testing. So we talked about testing for NMO antibodies. But what kind of tests we're looking for? Is it the cell-based? Is it the ELISA? And this is very important for our attendants today to understand what testing do you usually look for and which one has the highest sensitivity. We prefer to do the cell-based test, and it shows that it has the highest sensitivity. All of the tests in general, they're very specific for NMO, but the cell-based test has the highest sensitivity compared to other tests with very high likelihood ratio, positive likelihood ratio. I don't know, Dr. Suzan, what do you usually in your practice? Do you have access to the cell-based, or how do you request your NMO? How do you look for NMO antibodies?
Right. I 100% agree that the cell-based is the most sensitive, more specific, other than the ELISA or the fluorescence immunoprecipitation assay. But in our practice, this usually sent abroad, so that we get an accurate result. I will just add one point here. If I've mentioned that 1/3 of patients are IgG aquaporin 4 negative. But if our suspicion is high and the patient tested negative, then again we have to retest so as to just make sure that is truly negative patient. One more point just here regarding, as long as we mentioned the test, because we can, if the patient is negative for aquaporin 4, he might be a positive for anti-MOG. So if we have a double negative patients, they say that they have a better prognosis, a better outcome for double negative patients, better than the double positive patients. So this also has to be bear in mind.
Yeah, in fact, commercially, the available is the ELISA, but the cell-based is more sensitive. So if ELISA is negative, we go cell-based. But Roche now is providing to do the MOG antibody and the NMO antibodies via cell-based. They are, that's what I hear, I mean, supporting patient and doctors to do it in the country here. So some lab will collect blood and you can do it in the country. So you can get the result within 2 days. What we are doing now, we wait 2 weeks to get the result, whether it's ELISA or cell-based. So it is a very good support actually to do it within 2 days in some lab here inside the Emirates. One question here: if steroid fails, what next?
Are we talking about optic neuritis?
NMO spectrum.
Yes, yes.
Including
NMO
optic neuritis.
So as I mentioned, so we're talking about hyperacute treatment. So 48 hours, it seems that it's like you're dealing with a stroke patient. These are how I think about patients with optic neuritis related to NMOSD. How fast you start the treatment is how you would expect how effective would be the treatment. So if the patient fails, it depends on how far from the incident, the start of the symptoms. Is it long? Is it like a month before or just few days? It depends on the condition of the optic nerve. But I still consider also again, the last thing is the condition of the other eye. So if the patient has almost lost vision in one eye, I usually start Plex early on. So there are many players in the equation, and it's the vision, the main one, but others are also considered. I usually start Plex as soon as I suspect NMOSD.
So if you suspect NMO severe from the beginning, you start Plex, not steroids. Yes. I with or without steroids, but Plex will be on top of my list. And again, the vision. When I see a patient with vision worse than 2400, these patients trigger me for the treatment. If you look at the optic neuritis treatment trial, and most of these patients, they have MS related or idiopathic. Most of these patients have vision better than 2200. So it is atypical for a patient with optic neuritis related to MS or idiopathic optic neuritis to have vision worse than 2200. Okay, great, thank you. Question you answered already, Dr. Suzan. Should NMO spectrum disease patient receive vaccination against COVID?
Yes.
You said yes, irrespective of treatment?
Sorry, irrespective of treatment?
Whatever, yeah, if they are taking rituximab, for example.
Timing is important. We have to time the time for the vaccines with the timing, especially the patient like taking rituximab or like these sessions of treatment. If the patient is like Imuran, azathioprine, or is taking mycophenolate, they can't take their vaccine anytime.
Yeah, and B-cell therapy, rituximab, Ocrevus for MS, the timing usually, as I know, is 4 weeks before the dose, the infusion, or 12 weeks after the infusion. Because if you give it in the middle, they will not build immunity. There will be no immune response. So usually it should be before the dose or 12 weeks after the dose.
Yeah.
For all B-cell therapies in general.
Yeah.
This includes
Before-
Kesimpta, Ocrevus, and
Yeah. Towards the end of the cycles, before the second dose.
yeah. 4 weeks before the second dose or 12 after already infusion given.
Right.
There are some theories that no immunity better than COVID, so you have to take the risk and give it. But all trials or studies shown that no immunity if you give it shortly in relation in relation to the dosing. So it should be away from dosing. While other DMDs in MS and NMO spectrum can be given anytime. Question here. Dr. Luai, you answered many questions in writing. Should we allow people to hear the answer or no need?
Yeah, definitely. Which question?
Let me see. One question was at the beginning. Any relation between optic neuritis and thyroglobulin antibodies?
It's like what Dr. Suzan has mentioned. This is an autoimmune disease. It's different than MS, and you would think that there's cross immunity. So patients with NMOSD, they tend to have more autoimmune diseases like SLE or Crohn's disease, and that includes also thyroiditis. Yes.
Yeah. Okay. Thank you. Do you recommend to conduct mass screening? Yeah, you mentioned this. Dr. Suzan, what is the indication for you to go satralizumab? If patient is failing, we don't have approved therapy for NMO spectrum disease, except these monoclonal antibodies or interleukins. So what's the indication for you to escalate therapy or go for this therapy?
If I'm talking specifically about satralizumab, which is available now in UAE, so it can be used as add-on therapy and it can be used as monotherapy. So it can be used for naive patients or patients who fails the medication that they are already taking now. So that would be the indication for this new monoclonal antibodies.
Okay. Why do symptoms persist after relapse has recovered? In NMO spectrum disease, contrary to MS, MS patient usually relapse recovers, but in NMO spectrum, they are left with a deficit. Why is this? This is a question.
This is related to pathology of the disease itself, because as we mentioned that the pathology is completely different than an MS, and the disability here related to the relapses. So the patients, I don't know exactly why they still remain with this permanent disabilities or permanent symptoms or the sequelae of the disease, but this is how the disease it works. So this is the difference from MS. Yeah.
That's why it's very important what Dr. Luai mentioned at the beginning. We have to be aggressive before permanent disability happens, whether it's blindness, myelitis, paralysis, and so on. What should I do if I think I'm having a relapse? See the doctor.
Consult your neurologist, definitely.
Neurologist or ophthalmologist.
Or ophthalmologist, exactly.
Yeah. Or radiologist to do MRI for you. I think I'm searching if we have any more questions. In fact, most of the questions are answered. If you, the panelists, have any comments or questions, please go ahead. We have 2 minutes left.
I would just mention, as I mentioned earlier in the take-home messages, it's be alerted, look for atypical presentation, atypical features of optic neuritis, MS-related optic neuritis or idiopathic-related optic or idiopathic optic neuritis in general. Usually these patients recover even without treatment. If you have a patient with poor vision recovery, with simultaneous or sequential optic neuritis, these patients require more workup. One thing that maybe we mentioned already, that I screen for all of my patients, new patients with optic neuritis, for NMO and MOG. And I get surprised every time when I have a patient testing positive, when I think this is a patient with typical optic neuritis. So even in patient with typical optic neuritis, I still screen for NMO and MOG. One of the reasons is that after treatment, you don't know, these can turn to negative tests. So, but it's better to start with testing them before you start the treatment.
Great, thank you. Dr. Suzan, you have anything? There is one last question.
Yeah.
But if you have any comment? Yeah, please.
Yeah, the only comment that I wish I would encourage my colleagues for the differentiation between multiple sclerosis and NMOSD, because the differentiation, the appropriate diagnosis, the appropriate management is quite crucial in this condition. Because we saw many patients who were misdiagnosed as MS and they were taking medications for MS. So this is the only message that I would emphasize on.
Yeah, thank you. Last question. How does hemophilia affect on NMO spectrum disease with a patient who has bleeding? I'm not sure the association between hemophilia and NMO spectrum.
Not to my knowledge, no association. I'm not sure about this. I have no idea.
I have no idea. So we have to ask the hematologist. We don't have today. So today we have multidisciplinary discussion. We have, fortunately, ophthalmologist, neurologist, radiologist. This is a great opportunity to emphasize on the multidisciplinary approach for patients with demyelinating disease, especially in NMO spectrum. And we need the rehabilitation next step to be available with us. So I think with this, we covered most of the topics. We have 870 attendants already. And I would like to thank the speaker, Dr. Luai, Dr. Suzan, Dr. Alaa, for their excellent presentation, interaction. I want to thank the participants for the fruitful interaction. And I want to thank Roche for excellent support for patients and for NMO spectrum community in the country. And we'll thank the organizer, the MCO. So with this, we come to end of this excellent webinar. Thank you very much and good night.